Difficult airway algorithm. Latest updates. Complete clinical presentation lecture notes. 2025-2026 evidence-based updates. Why difficult airway algorithm? 1. It's a leading cause of anesthesia-related death. Failed airway management and hypoxia is still the #1 cause of anesthesia brain damage and death worldwide. Even with modern monitors, if you can't get oxygen in, the patient dies in minutes. 2. It's unpredictable but preventable. 30% of can't intubate, can't ventilate cases had no warning signs on assessment. But when we follow an algorithm, mortality drops drastically. Having a plan saves lives. 3. 2025-2026 guidelines have major updates. DOS 2015, ACA 2022, and UFSA 2024 changed practice. Video laryngoscopy is now first line, awake intubation is emphasized more, and scalpel bougie tube is the standard for CICO. You need to be current. Learning objectives. At the end of this lecture, participants should be able to 1. Define difficult airway. 2. Perform systematic airway assessment. 3. Identify predictors of difficult airway. 4. Apply the latest difficult airway Society DOS algorithm. 5. Recognize CICO situations. 6. Perform emergency airway rescue. 7. Choose appropriate airway devices. 8. Reduce airway-related morbidity and mortality. Introduction. Airway management is the single most important responsibility of the anesthesia provider. Failure to establish a patent airway remains one of the leading causes of 1. Brain injury. 2. Cardiac arrest. 3. Anesthesia-related death. Modern airway management focuses on 1. Planning. 2. Oxygenation. 3. Early recognition. 4. Limiting repeated attempts. 5. Early rescue techniques. The latest airway algorithms emphasize oxygenation over intubation. Current research findings. Recent international studies demonstrate 1. Video laryngoscopy significantly improves first-pass success. 2. Multiple intubation attempts greatly increase hypoxia. 3. Most airway catastrophes result from poor planning rather than of skill. 4. Early use of supraglottic devices improves outcomes. 5. Delayed front of neck access increases mortality. Current international recommendations strongly advocate 1. Video laryngoscopy is the preferred first-line device in anticipated both airways. 2. Universal capnography confirmation. 3. Limiting intubation attempts to 3. 4. Early declaration of CICO. Definition. A difficult airway is a clinical situation in which a trained anesthesia provider experiences difficulty with one or more of the following. 1. Face mask ventilation. 2. Supraglottic airway placement. 3. Laryngoscopy. 4. Tract intubation. 5. Extubation. 6. Emergency surgical airway. Airway management has 6 checkpoints. Difficulty at any one of them can lead to hypoxia, brain damage, or death if you're not prepared. Types of difficult airway. 1. Difficult face mask ventilation. Inability to maintain oxygen saturation above 90%. 2. Difficult laryngoscopy. Unable to visualize the vocal cords. 3. Difficult intubation. More than 3 or longer than 10 minutes. 4. Failed intubation. Unable to insert an endotracheal tube after multiple attempts. 5. Difficult extubation. Risk of airway obstruction after tube removal. Airway anatomy review. Know the anatomy of 1. Nose. 2. Mouth. 3. Tongue. 4. Soft palate. 5. Epiglottis. 6. Glottis. 7. Vocal cords. 8. Trachea. 9. Cricothyroid membrane. The cricothyroid membrane is the landmark for emergency surgical airway. Causes of difficult airway. Congenital. 1. Pierre-Robin syndrome. 2. Treacher-Collins syndrome. 3. Down syndrome. Acquired. 1. Tumors. 2. Trauma. 3. Burns. 4. Infection. 5. Lueg's angina. 6. Neck abscess. 7. Radiation fibrosis. Patient factors. 1. Obesity. 2. Pregnancy. 3. Cervical spine injury. 4. Rheumatoid arthritis. 5. Acromegaly. 6. Ankylosing spondylitis. Airway assessment. History. The history is the first and most important step in predicting a difficult airway. Asterisk. Before we touch the patient, before we open the airway cart, we talk. Reason. A good history can predict up to 30% of difficult airways and thus choose between plan A, B, C, or D before induction. We specifically ask about 6 red flags. 1. Previous difficult intubation. 2. OSA. 3. Snoring. 4. Neck surgery. 5. Radiotherapy. And 6. Trauma. Because these conditions change the anatomy, make ventilation harder, or mean we have less than 3 minutes to get oxygen in if things go wrong. In short, the patient will often tell you if their airway will be difficult, if you ask the right questions. Physical examination. Mallampati classification. Look inside the mouth, and the airway tells you its story. The Mallampati test is part of our bedside airway exam. It gives us a quick idea of how much space the tongue takes up versus how much room we'll have to see the vocal cord during laryngoscopy. We ask the patient to open their mouth wide and stick out their tongue. Then we grade what we can see from class 1 to class 4. Less visible structures equals bigger tongue. Or smaller mouth equals more likely to be difficult to intubate. In short, Mallampati is a 5-second test that predicts if the tongue will block our view. But remember, it's just one piece of the puzzle. We never rely on Mallampati alone. Physical examination. Airway. Mouth opening. Normal greater than 3 finger breadths. Thyromental distance. Normal greater than 6.5 centimeters. Sternomental distance 12.5 centimeters. Neck movement. Normal greater than 80 degrees. Upper lip bite test class 1, normal. Class 2, moderate. Class 3, difficult. 3-3-2 rule. 3 fingers mouth opening. 3 fingers mandibular space. 2 fingers thyroid distance. Measure the space, predict the difficulty. Beyond just looking in the mouth, we check if there's enough room to put instruments in and move them. Intubation needs space to open the mouth, room for the tongue, and ability to line up the mouth, throat, and trachea. We use quick bedside tests: mouth opening, thyromental distance, neck movement, lip bite test, and 3-3-2 rule. Because if these distances are small, your laryngoscope and tube won't fit, even with a good Mallampati. In short, good mouth plus good neck plus good space equals easier airway. Lemon assessment. Lemon helps you remember 5 quick things to look for before intubation. In an emergency you don't have time for a full exam. Lemon gives you a fast bedside checklist to spot a difficult airway. L. Look. E. Evaluate space. M. Mallampati. O. Obstruction. N. Neck mobility. In short, if lemon is positive, have a backup plan ready. Moans, rods and short. Moans, mask ventilation. 1. Mask seal. 2. Obesity. 3. Age greater than 55. 4. No teeth. 5. Stiff lungs. Rods, supraglottic airway. 1. Restricted mouth. 2. Obstruction. 3. Disrupted airway. 4. Stiff lungs. Short cricothyrotomy. 1. Surgery. 2. Hematoma. 3. Obesity. 4. Radiation. 5. Tumor. Plan A fails. A difficult airway has 3 danger zones: ventilation, rescue airway, and emergency surgical airway. These mnemonics help us predict trouble at each step. Before we induce difficult airway society. DOS algorithm. Plan A. Intubation. 1. Pre-oxygenate. 2. Position patient. 3. Use videolaryngoscope if available. 4. Limit attempts. 5. Confirm with capnography. Maximum 1. 3 attempts. 2. 1 expert attempt. 3. Then stop. Plan A is your first and best chance to secure the airway. The DOS algorithm gives us a step-by-step plan so we don't panic when things get difficult. In a crisis, structure saves lives. You follow the plan, not your fear. Plan B. Supraglottic airway. Insert second-generation LMA. Assess ventilation. If ventilation adequate, wake patient. Or proceed if appropriate. If the tube won't go in, but you can still ventilate. Plan B equals supraglottic airway rescue. Plan A failed for intubation, but oxygen is still getting in. Don't keep forcing a tube. We insert a second-generation LMA, check if ventilation is adequate. If yes, you have 2 choices: wake the patient safe, or proceed with surgery using the LMA if it's appropriate. Good oxygenation buys you time to think. A bad decision now turns Plan B into Plan C. Plan C. Face mask ventilation. Return to mask ventilation. Reverse anesthesia if possible. Wake patient. If you can't intubate, and you can't ventilate through an LMA. Plan C equals return to face mask ventilation. Plans A and B to secure the airway. We go back to basics: mask and bag. Oxygen first. We reverse anesthesia if possible and wake the patient. A patient breathing for themselves is safer than an anesthetized patient we can't oxygenate. This is not failure. This is damage control. Plan D. Emergency front of neck access, FONA. If unable to intubate and oxygenate, declare CICO. Perform emergency cricothyrotomy immediately. If you can't intubate, and you can't oxygenate. Plan D equals CICO. Emergency front of neck access. CICO equals can't intubate, can't oxygenate. This is the final airway emergency. When all other plans fail, we declare CICO and do an emergency cricothyrotomy immediately. We are out of time and out of oxygen. The only way to save the brain and save the patient is to make a surgical airway through the front of the neck, right now. Difficult Airway Algorithm 2025-2026. Step 1. Assess. Check the airway. Is it likely to be difficult? Step 2. Prepare. Get equipment ready. Get help. Plan A, B, C, D in mind. Step 3. Pre-oxygenate. Give 100% oxygen for 3 to 5 minutes. Maximize safe apnea time. Plan A. Intubate. Try to intubate the trachea. Success. Yes. Then proceed to surgery. No. Then go to Plan B. Plan B. Supraglottic device. Insert LMA, I-gel, SGA. Can you ventilate? Yes. Then continue anesthesia or wake the patient. No. Then go to Plan C. Plan C. Face mask ventilation. Go back to basic mask and bag ventilation. Consider reversing anesthesia and waking the patient. Can you oxygenate? Yes. Then wake the patient safely. No. Then this is CICO. Go to Plan D. Plan D. CICO. Then emergency front of neck access. CICO equals can't intubate, can't oxygenate. This is an airway emergency. Action. Perform emergency cricothyrotomy immediately. Life over everything. Pre-oxygenation. Before the airway is secured, fill the tank. Pre-oxygenation is your safety net. The moment we give anesthesia, the patient stops breathing for us. The only oxygen they have is what we put in before. Aim. To increase the oxygen reserve in the lungs and blood. To buy you time. To buy the patient life. Why it matters. A well pre-oxygenated patient can tolerate 8 to 10 minutes without breathing. A poorly pre-oxygenated patient may desaturate in 60 seconds. That difference is between a calm airway and a CICO crisis. Methods. 1. 100% oxygen for 3 minutes of normal tidal breathing. 2. Or 8 vital capacity breaths, 8 deep breaths in 60 seconds. 3. High-flow nasal oxygen, can further extend safe apnea time in selected patients. Apneic oxygenation. Keep giving oxygen even when the patient isn't breathing. Giving oxygen through the nose while you are intubating. Methods. 1. High-flow nasal cannula. 2. Nasal prongs left on during intubation. Benefits. 1. Longer apnea time. Buys more time, slower drop in oxygen. 2. Reduced desaturation. Prevents desaturation. Protects the brain. Video laryngoscopy. See better. Intubate safer. Using a camera on the laryngoscope blade to see the airway on a screen. Why it's first line now for difficult airways. Advantages. 1. Better view. You see the chords more clearly. 2. Higher pass success, get it right the first time. 3. Less neck movement, safer for trauma, spine patients. 4. Less trauma, gentler on teeth and tissues. Examples. Glidescope, CMAC, McGrath, King Vision. Awake tracheal intubation. Keep them breathing while you secure the airway. Putting the breathing tube in while the patient is awake, breathing, and protecting their own airway. When we know it will be dangerous to put them to sleep first. Because asleep equals no airway equals crisis. Awake equals safe. Indication. 1. Known difficult airway we failed before. 2. Airway tumor, the airway could collapse. 3. Neck immobility, can't move the head. 4. Severe obesity, oxygen drops fast. 5. Expected impossible mask ventilation, if we can't bag, we can't induce. Techniques. Topical anesthesia, numb the airway. Minimal sedation, keep them calm but awake. Flexible bronchoscope, see and guide the tube. Video laryngoscope, see on screen and guide the tube. Rapid sequence induction. Fast in. Tube in. Protect the airway. Putting a patient to sleep and intubating immediately. With no time wasted, and no chance for them to vomit and aspirate. When the stomach is full and the lungs are at risk. Every second counts. Indication. 1. Full stomach. Trauma, emergency surgery. 2. Trauma, can't trust what they ate. 3. Pregnancy, high risk of aspiration. 4. Airway obstruction, need the airway secured now. Use. 1. Liquid pre-oxygenation, fill the tank. 2. Fast-acting induction agent, knock them out instantly. 3. Neuromuscular blocker, paralyze immediately. 4. Avoid unnecessary mask ventilation unless needed for oxygenation. Because squeezing the bag can push stomach contents up. Supraglottic airway devices. When the tube won't go, put this in. A mask that sits above the vocal cords. No need to see the cords. No need to paralyze. Examples. iGel, Proseal LMA, Supreme LMA. Advantages. 1. Easy insertion. Fast, even under stress. 2. Great rescue device. When mask ventilation fails or intubation fails. 3. Useful bridge. Buys you time and oxygen while you plan the next step. Can't intubate. Can't oxygenate. CICO. This is the airway emergency. 1. Can't intubate. The tube won't go in. 2. Can't oxygenate. Mask and SGA won't work. 3. Oxygen is crashing. Seconds left. You have run out of Plan A, Plan B, and Plan C. There is only one thing left. Emergency surgical airway. Cut. Get air in. Now. Front of neck access, FONA. When all else fails, cut. Making a hole through the neck directly into the trachea. This is your last lifeline in a CICO situation. Preferred method. Scalpel bougie tube. Steps. 1. Identify cricothyroid membrane. Identify the cricothyroid membrane. 2. Horizontal incision. 1 horizontal incision through skin and membrane. 3. Insert bougie. Insert a bougie into the trachea. 4. Railroad cuffed tube. Railroad a cuffed tube over the bougie. 5. Inflate cuff. Inflate the cuff. 6. Confirm with capnography. Confirm with capnography. Pediatric difficult airway. Small airway. Zero margin for error. Challenges. Why kids are different. 1. Large tongue. Blocks your view. 2. Anterior larynx. Tube doesn't line up easily. 3. Small airway. 1 mm of equals 50% blocked. 4. High oxygen consumption. They desaturate in seconds. Management. How we manage. 1. Gentle ventilation. Don't force it. Don't traumatize it. 2. Age-appropriate devices. Wrong size equals no. 3. Experienced operator. This is not the time to learn. Obstetric difficult airway. Pregnancy changes everything in the airway. Risk factors. Why it's high risk. 1. Weight gain. Less room to see. Harder to ventilate. 2. Airway edema. Everything is swollen and bleeds easily. 3. Aspirations. Full stomach plus no time to wait. 4. Large breasts. Get in the way of laryngoscopy. Management. How we manage. 1. Videolaryngoscopy. See better. First pass matters. 2. Optimal positioning. Ramp them up. Left uterine tilt. 3. Early help. Call for backup before you need it. 4. Second generation supraglottic airway. Your rescue bridge. ICU difficult airway. The sickest airways. The smallest margin. Problems. Why ICU patients crash. 1. Hypoxemia. They start low, and fall fast. 2. Shock. BP crashes the second you induce. 3. Acidosis. They can't tolerate apnea. 4. Full stomach. Aspiration is always waiting. Management. How we manage. Optimize physiology before intubation. Every time you can. Human factors. Most airway disasters aren't technical. They're human. Major contributors to airway disasters. What kills patients? 1. Poor communication. Nobody knows the plan. 2. Panic. Brain shuts down. Hands rush. 3. Fixation errors. I must get this tube, while SpO2 crashes. 4. Fatigue. Tired brain misses what's obvious. 5. Poor teamwork. Everyone doing their own thing. 6. Failure to call for help. Ego then airway then life. Airway drugs. Drugs don't secure airways. People do. But the wrong drug kills fast. Induction. 1. Propofol. Fast, smooth, hypotensive. Your default in the stable. 2. Ketamine. Pressure up, bronchodilator. Friend in shock and asthma. 3. Etomidate. Pressure neutral. Your go-to in the crashing. Neuromuscular blockers. 1. Rocuronium. 1.2 mg per kilogram for RSI. Reversible. Your workhorse. 2. Succinylcholine. 60s onset. 5 minutes off. Fastest in, fastest out. Reversal. 1. Sigamidex. Reverses rocuronium in 3 minutes. Your undo button. 2. Neostigmine. Old school. Slow. Needs glycopyrrolate. Topical anesthesia. 1. Lidocaine. Blunts cough, blunts gag, buys you time for awake. Airway equipment checklist. If it's not on the table, it doesn't exist in a crisis. For the airway. 1. Laryngoscope. Direct. Your backup. 2. Videolaryngoscope. First line. See what you're doing. 3. Bougie. Go. Lifesaver. When you see nothing but epiglottis. 4. Stylet. Shape the tube, beat the angle. 5. Endotracheal tubes. 6.0 to 8.0. Cuffed, checked. For ventilation. 6. Face mask. Seal saves lives. 7. Oropharyngeal airway. Stop the tongue. 8. Nasopharyngeal airway. Awake, bloody, or both. 9. LMA. Plan B second gen if you can. 10. Bag valve mask. Oxygenate between attempts. 11. Oxygen source. High flow. Apneic oxygenation. 12. Suction. Blood and vomit don't intubate themselves. 13. Capnography. If there's no CO2, you're in the wrong hole. For the last resort. 14. Cricothyrotomy kit. CICO. Scalpel, bougie, 6.0 tube. Nursing responsibilities. The airway doesn't belong to the doctor. It belongs to the team. Preoperative. Set up for success. 1. Assess airway. Big beard, small jaw, big problem. 2. Prepare equipment. Laryngoscope, bougie, LMA, cric kit. All of it. 3. Check suction. If it doesn't work, you will drown. 4. Verify oxygen supply. No O2, no intubation. Intraoperative. Eyes on the patient, not just the tube. 1. Assist intubation. Hand the right tool, before they ask. 2. Monitor. SpO2, ECG, BP, ETCO2. Numbers crash before people do. 3. Document attempts. Time, who, what, how many. Check the patient and the team. Postoperative. The airway isn't safe until the patient is awake. 1. Observe airway patency. Watch the chest rise. 2. Monitor for stridor. That noise is an emergency. 3. Assess respiratory distress. Work of breathing to truth. 4. Prepare for re-intubation. Hope for the best, set up for the worst. Complications. The price of getting airway management wrong. 1. Hypoxia. Brain dies in minutes. 2. Aspiration. Stomach in the lungs. Pneumonia follows. 3. Dental injury. The lawsuit you didn't expect. 4. Airway trauma. Bleeding, swelling, you just made it worse. 5. Laryngospasm. Vocal cords slam shut. 6. Bronchospasm. Wheezing, can't ventilate, can't oxygenate. 7. Esophageal intubation. You're ventilating the stomach. 8. Cardiac arrest. No oxygen, no pulse. 9. Death, the final complication. Key recommendations. Airway rules that save lives. 1. Assess every airway. Predict the problem before it owns you. 2. Always have plans A to D. If plan A fails, you already know plan B. 3. Pre-oxygenate effectively. Oxygen is time. 4. Use videolaryngoscopy early when indicated. See first, then tube. 5. Limit intubation attempts. 3 strikes and you switch. 6. Confirm tube placement with continuous waveform capnography. No CO2, no tube. 7. Prioritize oxygenation over intubation. Breathe first, tube second. 8. Declare CICO early. Can't intubate, can't oxygenate. Say it out loud. 9. Perform front of neck access without delay when indicated. Cut first, think later. 10. Practice airway algorithms regularly through simulation. You don't rise to the occasion. You fall to your training. Clinical pearls. Lines you should hear in your head during every airway. 1. The first attempt is the best attempt. Every try makes it harder, bloodier, and swollen. 2. Oxygenation is more important than intubation. A tube in the wrong place is useless. Oxygen matters. 3. Do not persist with repeated failed laryngoscopy. 3 attempts. Then stop. Switch plans. 4. Call for help early. Ego kills. A second pair of hands saves. 5. Always have a rescue plan before inducing anesthesia. If you can't wake them up, you better know plan B, C, and D6. Waveform capnography is the gold standard for confirming tracheal intubation. No wave, no tube. Trust the capnography, not your eyes. Summary. 1. The modern difficult airway algorithm has evolved from an intubation-focused approach to an oxygenation-focused strategy. 2. Success depends on meticulous assessment, preparation, limiting repeated attempts, early use of rescue devices, and prompt transition to emergency front of neck access when a can't intubate, can't oxygenate (CICO) situation occurs. 3. Adherence to contemporary guidelines from the Difficult Airway Society (DOS), the American Society of Anesthesiologists (ASA), and other international airway organizations has significantly reduced airway-related complications and mortality. Viva questions. 1. Define a difficult airway. 2. What are the components of the Lemon assessment? 3. Explain the 3-3-2 rule. 4. What are the 4 plans, A to D, in the DOS difficult airway algorithm? 5. What is the maximum recommended number of intubation attempts? 6. Define a CICO scenario. 7. What is front of neck access, FONA, and when is it indicated? 8. What are the indications for awake tracheal intubation? 9. Why is videolaryngoscopy increasingly recommended as first line in anticipated difficult airways? 10. Why is continuous waveform capnography mandatory after tracheal intubation? 11. List the predictors of difficult mask ventilation. 12. Name 3 second-generation supraglottic airway devices. 13. What are the major causes of failed airway management? 14. How do you optimize oxygenation before induction in a critically ill patient? 15. What are the common complications associated with difficult airway management? Thank you for watching. If you liked this content, don't forget to like to show your support. Comment and share your thoughts. Share with your friends and family. Subscribe for more exciting content. Your engagement means the world to us. Stay tuned for more.